It's too bad I didn't get a chance to run into you at the conference in DC.
I know. And I'm trying to remember when I had first heard you on a podcast. I'm trying to remember which I listened to so many of them. I can't remember which one it was that you were on, whether I don't know if it was like Dr. Yami in the summer time frame. And then that's when I got your book. And everything you said on that podcast was like, wow, this really resonates with me. And so I got the book. I started listening to the podcast. I listened to probably many of the episodes on your podcast already. And that actually just really started helping me take care of myself some more as well. And then also to be able to work with my patients.
You're unique in that you are living with and have been battling fibromyalgia and related struggles, and yet you're also a healthcare provider. We're excited to have a special guest. Her name's Laura Valero, and she has a unique perspective of both someone living with fibromyalgia and related conditions, as well as working as a clinician, as a nurse practitioner. She connected to me through the podcast as a listener, and she was sharing before that we were at the same conference, and you were recently listening to an episode where I was interviewing Dr. Dirksen, and he was presenting at the conference talking about reversing rheumatoid arthritis and osteoarthritis and using a healthy whole food plant-based diet. And that was at the International Conference on Nutrition and Medicine in DC. So welcome to the podcast.
Thank you. I am very excited to be here. This is actually my very first podcast. So
We're so lucky to have you share your wisdom and insights and experiences. So tell us about yourself and your background.
sure. As you mentioned, I'm a nurse practitioner, but that's something that I started late in life. I was pre-med many moons ago at Washington University in St. Louis. And at the end of my time there, I decided that I would go into the Air Force instead. And I decided to not take the MCATs and go to a medical school. So that set me down a completely different path as an intelligence officer with the Air Force, which took me to many exciting places. Korea, we were also the very first who were deployed to Desert Shield and Desert Storm back in 1990, which has an impact on my fibromyalgia and my rheumatoid arthritis today. Then after I got out of the Air Force, I worked for the Federal Aviation Administration for many years, also in Intel, and then ended up at the Transportation Security Administration when it was first created. And then when I came back to the FAA, I was no longer in Intel. I worked in emergency preparedness and disaster management. And that was when we were first starting to do pandemic planning. And just by happenstance, my manager said, "Hey, Laura, why don't you write the FAA's pandemic plan?" This was in 2005. And I was very excited because I was the only person in the office who had a quasi-medical background. I had a degree in biology. So I jumped at that and quickly realized that it was more than just writing a business continuity plan. There was a lot that we had to do at the strategic level to address protecting air traffic controllers during a pandemic when they can't wear masks and things like that. They can't social distance, developing the telework plans and implementing the telework plans. But also, how do you deal with an aircraft who's coming inbound from another country that may be full of sick people? So I ended up doing a lot of work at both the national and international level, developing those airport plans for managing inbound aircraft with patients with communicable disease. So that was a lot of fun, but very stressful. And I eventually was able to take early retirement in 2013. And at that point, I had all of this experience working with the CDC, with the World Health Organization, and that really whet my appetite. I really still feel that calling to go into medicine in some way, shape, or form. I'd also taken care of my mother for 13 years, culminating in her passing on July 4th of 2018. And so I had a lot of experience with taking care of her and managing her conditions and hospice and things. So that too also really put that idea in my heart that this was something I needed to do. So When they offered early retirement, I jumped, and then I became a nurse and then eventually a nurse practitioner. Throughout all of that, while I was in nursing school, I was looking for cookbooks for my daughter who was vegetarian. At that time, I was a full omnivore. And I read the China study by T. Colin Campbell and recognized that this is really good, solid science. And at that point, I was dealing with melanoma cancer, not really any other health issues at that point, other than my hands hurting. And went ahead and changed my diet at that point and had some immediate improvement in my seasonal allergies disappeared, my hand pain disappeared. I just felt like $1,000,000. That really started my journey down into the whole food plant-based world. I eventually got my certificate from Cornell University in nutritional studies, then also was able to be board certified as a lifestyle medicine professional through the American College of Lifestyle Medicine. And I'm also a Food for Life instructor with the PCRM.org, who hosted that conference that we went to. So I've been able to do a lot to help my patients. I became a nurse practitioner almost 4 years ago, and I knew that's really where I wanted to be and have had a lot of success with my patients, helping them manage their chronic disease. For those that want to really make those changes, for those that don't, I support them however they need that support. But for those that really can make lifestyle changes, I really see the most changes with them. Along that time frame, I was eventually diagnosed with rheumatoid arthritis. I already had the Raynaud's, I had the migraines that I was already dealing with. And then about last May timeframe, I was also diagnosed with fibromyalgia and started managing that, taking some Lyrica, which has been very helpful. I've never had to take medications for my rheumatoid arthritis because it's been so mild at this point. And I hope with my plant-based diet and exercise and stress management and good, healthy sleep that I will keep it that way. I don't want to get down into the methotrexate and all of those no fun medications. So then at that point, after I started reading your book, and I had always suspected for probably 25 years that I may have had ADHD. I had two of my neighbors who had ADHD tell me, Laura, you've got this. I've always been very messy. The desk behind you would probably be all full with papers if my husband hadn't gone through and cleaned everything up. So after reading your book and listening to your podcast, I decided I'm tired of dealing with this and not really managing it very well, and was able to be seen and was also recently diagnosed with ADHD and have started on the Adderall as well. And I remember my first comment back to my psychiatrist was, wow, is this what normal feels? Because for the first time, I've been able to really focus on getting all of my tasks done. I'm able to actually finish all of my charts for my patients by the end of the day, which I was not doing before. And so that has been very life-changing for me. So as I've been learning more about fibromyalgia and especially all of the related conditions that you wrote about in your book and have talked about in your podcast, I've been able to start helping my patients as well. And we're in the baby steps with that. I basically refer them to your podcast and your book. And so I haven't heard anything back yet because, like I said, it's just been in the last couple of weeks that we've really started bringing this in. So I'm hoping to be able to do more with my patients and to be able to help do those diagnoses as well. I think when I first started as a nurse practitioner a couple of years ago, I didn't obviously did not have nearly the clinical experience to be able to make those types of diagnoses. But as I've gotten that experience, I feel a little bit more confident. And I know my patients themselves are very frustrated and because they have all of these symptoms and they're not really getting the right medications. They can't get into with rheumatology because rheumatology won't treat them. So I'm hoping to be able to pay it forward and be able to help them feel better.
Yeah. So thanks for your service to our country. And you've had a exciting journey. And then, unfortunately, the last few years, having developed some health conditions, similar to myself, got interested into plant-based eating when my wife, a dietitian, who said you should read this book called The China Study. It was a continuing education. I had heard of things before in the past. When I was in the 90s in med school, I heard about Dean Ornish, and prior to that, you hear about low-fat diets, which then there was low-fat licorice, low-fat muffins. Nobody ever was marketing that. We didn't understand not having a bunch of refined white flour, etc. So then you get diagnosed with both RA and fibromyalgia, and you're a nurse practitioner, and you're going through this, and then the ADHD diagnosis gets put together, and you had heard me, which made you want to learn more about fibromyalgia, and then that connected the dots.
It really did. And especially when I learned about all of these other symptoms, all these other conditions that I had, the migraines and the Raynaud's, it was like, wow, they are all really interrelated. That blew my mind. That never came up in any of my studies as a nurse practitioner or my experience as well. But it's very compelling that the research there showing that hypersensitivity affects us in many different ways. And one of the things that I have noticed, let me step back a little bit. So one of the things that, as I was delving into doing more of the whole food plant-based, I've been trying to avoid medication to the extent possible. And I think by doing so, for my rheumatoid arthritis, for instance, we know I probably am not going to have to take any medication for hopefully a very long time. So I had been really reluctant to really go into any type of medication. I wanted to try to heal my body as best as I could using the 6 pillars of lifestyle medicine. But really in this last year or two, I was getting to the point where realizing that may not be enough, and recognizing that it is okay when appropriate to take medication. So by starting the Lyrica for my fibromyalgia, which I mostly only take at nighttime because during the daytime, it just gives me too many symptoms. But that has been a game changer for me. And then the other thing that I had noticed with starting the Adderall for my ADHD was that I'm not as focused as much on my pain like I was before. And that was really significant because before it seemed like all my thoughts were centered around the pain. I'm also dealing with a meniscus repair that's not gone well, and I may end up having to have a total knee replacement in the near future. But treating that has allowed me to get through my day without being in as much pain. I'm sure the pain is still there. I'm just not perseverating on it like I was before.
Who made the diagnosis of fibro?
So I have been going to a psychiatric nurse practitioner.
And they made the diagnosis of fibromyalgia?
For the fibromyalgia? Yes. So that was, I'm sorry, no, for the fibromyalgia with the nurse practitioner in my practice.
A family practice type nurse practitioner.
Mm-hmm.
And what did they tell you what fibro, like how did they make the diagnosis? What did they say about it?
So we basically went through my entire history and I had suspected I'd had it many years ago, just based back when we were doing the tender points and things like that. And so we went through my entire history and my symptoms. We went through the various questionnaires, and that's how we were able to come up with that diagnosis. Also, I was in the Gulf War, and that condition is presumptive for when we're talking about disabilities that are managed through the VA. So many of us that were in the Gulf War who were exposed to the burn pits are now developing these types of symptoms.
Yeah. So post-Gulf War syndrome.
Yeah.
Get the diagnosis, and what did they say it was? What caused it? And what was the solution? What were you told?
So we were approaching it from the perspective of having been in the Gulf War. And so we didn't really get into any discussion about what caused it, other than obviously I'd had this lengthy exposure when I was deployed overseas. And so, yeah, we didn't really get into that at all. And we didn't make the linkage either with my migraines and my Raynaud's as well. So the main treatment that we've been using has been the Lyrica. And like I said, that's been very helpful. I had not realized that I had not been sleeping well. And so having the Lyrica, especially at bedtime, has been very helpful in that regard.
Looking back, you've had this for a while, but didn't
Mhm.
have a name, but you heard somewhere along the line about fibromyalgia. Is that when you were getting into the medical field as an RN, you heard the word?
Yet I had been contemplating or thinking about it probably 15 or 20 years ago. That why is it that I hurt everywhere all the time and there's no real injury or anything like that?
So as a layperson, you weren't an RN yet. Is that correct?
Correct, correct, correct.
And the internet and information probably was pretty rudimentary back then. There wasn't a lot of great information probably about it.
Very much. Yeah, exactly, exactly.
And did you ever go to a doctor back then and ask about muscle soreness and fatigue or brain fog? Did you ever, in any of your physician encounters in the past, bring that up?
To be completely honest, I did not. And I thought, I think I was embarrassed to really bring those types of things up. I didn't know that I would really be taken seriously, that, oh, it's just like female stuff or that. So I did not bring it up. I just basically suffered in silence for a long time. And yeah,
Why do you think there was embarrassment? Why do you think you felt embarrassed?
I wish I had a good answer for that.
That's something you saw in the military aspect. If your leg's not broke and it's not hanging, you just keep moving along. Is that
Right.
part of that?
Part of it, yeah, we call it the suck it up buttercup phenomenon. But I think also at that time frame, I was working up in DC and taking care of my mom, lived with us for 13 years. I had 3 kids, so I had that sandwich phenomenon going on. And the other part of it too was that I just didn't really have time to take care of myself. And that happens a lot, and I try to work with my patients to remind them that to taking care of the caregivers probably should be the first priority.
Yeah, I just bring that point about embarrassment. I think what's many people, and probably patients of yours and patients that of mine who are coming to see me, who've heard the podcast or been to many doctors before, new to me, is they've been to so many doctors for these complaints over the years. They've just learned that you just stop bringing it up because you're fine. You look fine.
Right.
And all the labs are normal. And what do you want me to do? You've been to rheumatology, you've been to pain management, you've been to all these doctors. What do you expect me to do? And what I find, and I don't know if you're starting to see this, I just saw somebody a couple days ago who had isolated symptoms, came in for one thing, but we started asking, and there were 15 out of 19 areas of pain on the widespread pain index. She didn't come in that day with a chief complaint, but since I asked, yes. And of course, I think there's the assumption that if you're a 60-year-old woman, that you come in and you have all these complaints, but you walked in and you look healthy and you've had this for years, you would have died if it was metastatic breast cancer by now. And so you're fine. So I don't know. What are your thoughts on that?
I would completely agree that we do tend to kind of stuff our complaints and not really spend a lot of time thinking about them. So I definitely have the same thing with some of my patients as well, where it's about opening up that conversation with them and really digging into what's going on with them. It's hard to do in the primary care world because for the most part, we may not have enough time to really dig into a lot of that.
The same patient said to me, who had been to like back pain. I have chronic back pain. That's my thing. I got chronic back
Mhm.
injections, had spinal surgery, still struggling.
Oh, wow.
And yet had 15 out of 19 areas on the widespread pain index. If you don't know what the widespread pain index, go to one of the early episodes on Do I Have Fibro? She didn't bring that up. And she asked her primary for an opinion on her pain, and her primary said to her basically, just stop looking for answers,
Oh, wow.
which was discouraging. In other words, stop thinking about it, which is sad. But I think that's often what is probably felt when you're on the side as a clinician taking care of somebody like this. You're fine, is the impression.
Mhm.
I don't have anything else to offer. I don't think anybody else is. You obviously walked in here, your leg's not broken. You don't have multiple sclerosis. What do you think when you look at your perspective, maybe in the past, and other clinicians that you shadowed when you were in nurse practitioner training, when you see these patients, or colleagues of yours? What do you think about the perspectives that often is there by clinicians and nurse practitioners and doctors?
Again, we're not really trained a lot about it, about how to diagnose fibromyalgia. And we've done all the tests, all of the rheumatoid panel, all of those things all come up negative. And you're right, it is very frustrating because there are not enough primary care providers out there who are comfortable with making these diagnoses. And so they try to maybe farm it off to pain management or try a rheumatoid, but rheumatoid won't take anybody unless they have a diagnosed autoimmune condition. So I think this is a really big problem. I think there are probably a lot more people out there, a lot more patients out there who are suffering from fibromyalgia and related conditions. I think the other issue, as you may experience as well in your practice, is in primary care, we have so little time to be able to do those in-depth analyses and discussions with the patient to really pull out all of their symptoms and to go through the questionnaires and to get their very detailed history. When you're given that 15-minute appointment is really only 10 minutes with the clinician. And so it really entails then bringing them back for multiple visits or trying to schedule a 30-minute appointment, which may or may not work with the schedule. Fortunately for me, where I'm at, my census is decent enough that there are times that I can carve out to be able to do a little bit more in-depth work with the patient and to try to do a little bit more of that teaching. Even like for the diabetes and things like that, I spend a lot of time teaching them.
Yeah, it's so important. And I think it's important for listeners out there who are not clinicians, that are patients living with this from that perspective. You're relatively recent minted nurse practitioner, which means you went through this. How much education did you get on fibromyalgia for your nurse practitioner training and certifications and just clinical observations?
Not
Clinical.
other than a very broad brush about what it might be. Nothing, not really much at all. No.
And we talked about ADHD. How much training did you get on ADHD as a nurse practitioner?
A little bit. We had our psych modules and whatnot. But again, it's not really in depth. Most of the focus that we had would have been more on the diabetes and the hypertension, all of those chronic diseases that we typically see in our patient population.
So you've gotten the chance to spend a few years doing primary care now. When you look at what you mentioned as the frequent follow-ups and chronic illnesses as stereotypically under the realm of a primary care doctor, how much chronic pain do you think there is in primary care that goes underlooked, that is not really addressed and dismissed for the relatively easy things like diabetes, high blood pressure management, for example?
There's a lot out there. I don't know if I could put a number like on my particular patient load, but I would say probably at least 20% of my patients are dealing with some type of a chronic pain. We have a lot that have identified back issues. So we send them to physical therapy and whatnot, the standard, or the possible rotator cuff issue or the knee arthritis and whatnot. But now that I'm looking for it more, perhaps, that I am seeing definitely a lot of patients. They're coming in, I'm so tired all the time. Why am I so tired? Well, let's check this and this. And of course, nothing comes up. So we're starting to get those conversations. We're starting to
Yeah.
get conversations there.
How much has reading the book and listening to the podcast helped you understand more about these?
It has helped tremendously, especially making those connections with some of the other types of the ADHD and the migraines. I've had a number of patients that have migraines, that have IBS. And so now we're starting to introduce having those conversations. What else? Where else are you having issues? And trying to start to address those.
Yeah. It's interesting to see all of these connections over time. How has that impacted you caring and supporting the patients just in the last couple months with the insights you've gleaned both with your journey and what you've learned? How has that changed how you care for those patients? Like, what would you have done previously, maybe a year or two ago, before what you've learned? And now, how is your approach different?
So before I would have what I was doing, again, we would do the labs and when we weren't really coming up with anything, it would just be left there. I would try to encourage them to eat a healthier diet, to start to exercise, address the 6 pillars of lifestyle medicine and see if that helped them at all. But we didn't really have that space to really start to explore. But now, as a patient, I've always had a lot of empathy for my patients, but even more, I have a better understanding of what they are going through, the challenges that they may have had in the past, including with my own self, with identifying issues. And so I think we're going to be in a much better place going forward.
And what has that brought when you see somebody on your schedule now who has fibromyalgia or has symptoms and they're starting to report this? How has that impacted your satisfaction for caring for those patients and hopefulness for caring for them compared to before?
Oh, tremendously, because now I feel like I have some tools to be able to help them because we knew we couldn't get them over to the rheumatologist. And I've always felt a little bit helpless, apart from maybe prescribing some Cymbalta or maybe some gabapentin or Lyrica. I did not feel comfortable with being able to help them. But now I can help them really connect the dots themselves. You'll understand what how this is happening, explain to them kind of the underlying pathophysiology. And I think once patients understand why this is happening, then that helps empower them to be able to take a little bit more action on their own and to be proactive. I have referred several of them to psychiatry as well. If we identified that maybe they may have some ADHD or some other underlying mental health issues, getting them seen with psychiatry as well.
And how has psychiatry in your area been when you're pretty confident somebody has ADHD? Are they in your area pretty comfortable in diagnosing and treating that with stimulant medications?
Pretty much. I think the biggest problem I have is with my patients who have Medicaid and Medicare, because there are no psychiatrists in our area that take those insurance. Or if they do, they might take one flavor of Medicaid because we have all of the different, the Anthem, the Aetnas and Molina and whatnot. where they may only take one and not the other ones. I don't understand that. We take all of them. So that's my biggest challenge, is finding somebody. And some of my patients have to travel an hour or 2 hours each way to get a psychiatrist who takes Medicaid. But fortunately, once they establish, they will able to do the telepsych appointments, at least for now, But it's a challenge to be able to get them to get that care. With my patients that have commercial insurance, it's not a problem. That, like, the psych NP that I see takes all the commercial and he gets everybody in, where we have a number of other ones. And then the other bigger challenge is for those who don't have insurance. And that's a really big challenge, getting them in with psych, because a lot of times they can't afford it. The other population that I am really trying to focus a lot of this on is the Hispanic population, many of whom unfortunately do not have insurance. But I am the only Spanish-speaking provider in my local area. I work in a small rural clinic about an hour away from home. And so getting the resources for them is really super challenging, especially psychiatry, because we have no Spanish-speaking counselors or psychiatric providers anywhere close to us.
Within your practice, is it a family practice clinic, or is it internal medicine, peds, family practice? Is it what kind of?
It's a family practice. We're a very small rural clinic. Right now, there's 2 providers.
Family practice physicians and then NPs with them, or just you and an FP?
So it's myself and a PA, and we have a supervising MD.
At the clinic location?
He's actually remote. He owns the 2 clinics, and we confer with him on a very close basis.
Sure. Just curious, have some flexibility. You're doing education, you're teaching them, you're referring them to the podcast, reading the book to help them have insights. How comfortable do you feel in your own journey about diagnosing ADHD? You mentioned you were diagnosed in reading. How comfortable do you feel now in diagnosing ADHD?
That I don't feel comfortable with. And in our particular clinic, with the guardrails that we have with prescriptions, I would not be able to prescribe stimulants. So we have to refer that out.
Is that within what the guidelines are within the family practice doctor that manages, oversees, has said we don't want to prescribe opioids out as very short term or any controlled substance that's a level 2? Is that kind of the
Correct.
Don't want to get our hands dirty. Don't want to take a chance with that. Is that one of the
Yeah.
understood? Stay in our lane, so to speak.
Exactly. I can provide bridge prescriptions. We have a number of people that move into the area. I can give them a short prescription to tide them over. But for me, the controlled substances, I'm pretty much limited to gabapentin and Lyrica is what I prescribe predominantly.
Sure. And those are essentially controlled because if you use them with an opioid and benzodiazepine at high doses, they could, in combination, cause respiratory suppression, but by themselves are very safe, very helpful, especially if taken at night. One of the mistakes sometimes people will have, I tried that, it didn't work, and made my brain fog worse. And it's no, you'd only take it at night. If you take it during the day, and often these are people who had untreated, unrecognized ADHD, so it makes their actual ADHD symptoms worse on top of.
Oh, wow. Yeah.
Do you have any thoughts or questions for me?
I guess, what guidance would you offer to new practitioners? So I'm not quite a new practitioner. I'm a quasi-new. I'm a practitioner.
That's really interesting. As I'm learning and just interacting with different clinicians at a new location, since my non-compete is done, and getting a chance to interact with NPs, PAs, primary care docs there, it's pretty par for what you're experiencing. Very little training, very simple regimen. It's very much the biomedical approach. We talk about try duloxetine and try Lyrica, and it's like telling somebody to go to the gym and exercise. That could be injurious if you don't exercise properly. If you don't know how to use the weights, you could rupture a bicep tendon, throw your rotator cuff out trying to do some bridge pose in yoga. cause more harm without proper guidance. You get a couple slides at a continuing education lecture on orthopedics, joint pain, and it mentions fibro, and here are the FDA approved medications, right? And that's probably, you say, Barry, you have maybe a paragraph, and here's the FDA meds approved, and there isn't any guidance on even how to use them. I would say that, one, don't be afraid to make the diagnosis and use the widespread pain index and symptom severity score and make the diagnosis. I would say that before you order the test, you've already done the widespread pain index and symptom severity score, and you've done a review of systems, and you ask how long you've had these symptoms, and say that's okay. And you don't have to, a lot of people have this, who have IBS, have migraines. A lot of people with migraines have painful periods. How bad were your periods before menopause? A lot of people with fibro, their symptoms worsened after menopause. How much did your symptoms worsen? Or did some get better, some get worse? So that is one thing. Before you order the test, say, just so you know, I'm expecting these labs to be normal. So when I call you, that's okay. Because what I'm looking for is that if you have severe joint destroying inflammation in your body, I don't see that on your exam. Your joints look fine. So I'm not expecting that. In fact, if I do find something wrong, I'm going to probably repeat it because I don't think it's going to be accurate because it doesn't fit clinically. But that doesn't mean you don't have pain, but it doesn't mean you have tissue injury. So when you get those results, that's what we're expecting. And then also do the Fibromyalgia Impact Questionnaire. We do the PHQ-9 and have that in the room. We have those in our rooms now.
Oh, yes, we do too.
They, okay, fill these out. I'm going to go to the next patient who might have a real simple problem. They have an ear infection. You're just helping them for their ear infection, strep throat. You get done in 5 minutes and you come back in and they filled it out. One of the things that you often hear is that didn't work. When you work with fibromyalgia, you do not get a cure like you do with strep throat or a urinary tract infection. You don't get 100% cure. So if somebody starts on Lyrica and they say, it didn't work, or I tried those meds, they don't work. Nobody told me that they were going to work 25%. And I don't even know what 25% is because I don't have a Fibromyalgia Impact Questionnaire revised score here to know that I was at 77 and it dropped it down to a 50. Right? And if you don't have that, you can't see partial. And that's pretty much the nature of this, is that there's partial improvement. I like doing follow-up widespread pain index and symptom severity score. And they go, oh, I saw you last time you had 15 areas of pain. Now you have 7. Oh, I forgot about that. Because when something stops hurting, you don't notice it. If it's not noticed, you don't report it and it's gone. And how do you quantify some of these? And if you use that, like I have that in the book and bring that as a tool, that's important to know. And then what I think is, what I find helpful, and you've heard this on the podcast, I'll say, hey, I love helping people like you. You're my favorite group of patients. You know what this patient said who had back pain? She said, do a lot of your patients cry when they see you? And I said, sometimes they do because they actually have somebody who cares and listens to them.
That's it. Yes.
And I said, and that's usually a good thing if somebody cries, and that's okay, because when your last doctor said, stop asking questions, and now you have somebody who wants to ask all these questions. Does your shoulders hurt? Your knee, upper and lower arms, your hip, that? Yes, and you can have, that's okay. What I also is really important, I've shared this with my patients, and I often go over. I skip lunch. I have 2 cups of oatmeal with a cup of blueberries for breakfast, so that can tide me over. I got some dates in the lunchroom and some leftovers that I can quick grab. But I can make it 7 hours of a low glycemic, eat breakfast like a king. And lunch like a prince. So I can sometimes go over and spend time, and people know if I'm running late. Like, I know why he's running late, because he cared for somebody just like me last time.
Exactly.
And so I'll say, I want to know your story, and I don't have enough time, but I want you to do something. I want you to write your story from when you were an infant, which you don't remember, but ask your mom, your big sister, what kind of baby were you? And
Mhm.
I've talked about this on the podcast, but colic is the first nociplastic or centralized pain, chronic pain syndrome.
Mhm.
So if you were like, were you a good baby? Ask your mom and just get the honest truth. And usually they don't have to ask. They're like, they always said, you were such a bad baby. You were much harder than your brother. We were almost not going to have another brother because you were so hard. You never wanted to go to sleep. You always cried. You had to be rocked. You didn't sleep through the night. And then what was on 5-year increments? What are your highlights? I was super active, really smart. I talked a lot. Or I remember getting nervous at school and getting headaches or stomach pain, or I got constipated. And as a kid, growing pains. And then you hear about ACEs, adverse childhood experiences. And then you
Right.
hear about family history. My parents divorced when I was 6. Why? My mom was a big drinker and got into using drugs. Oh, that keys me into wondering, do you also have a genetic inheritance susceptible for
Mhm.
ADHD? Oh, what about your periods when you were in high school? Did you have pain compared to your friends? Did you get migraines? Did you get this? What happened? And I say that in 5-year increments.
Mhm.
And for every decade, it's about a page of a summary of these co-occurring things, social, environmental things that were going on in life, whether you had symptoms or diagnoses, or maybe your family was suck it up buttercup and we never could afford to go to the doctor. So I learned to not complain. And then if you're 60, you might have 6 or 7 pages. People are very receptive if they have that, because I get a chance to see the narrative. And they get to see a doctor actually cares to hear their story,
Yeah.
because I can look through that quickly and I'll look through after the fact. And now I get a better story. And guess what? You get to understand, wow, now I know why my triggers, what causes flare ups. And I just saw this morning, she has work stress and she is moving. And we're in Wisconsin and it's the winter. And
Right.
this recording, her fibromyalgia impact score went from 60 to 88, and not one medicine changed.
Mhm.
The environmental stress is through the
Yeah.
roof. And so part of that is just, okay, that's there. And this is real. And the other thing, the education is so important. You mentioned something about if it's real. And this is, I think, a really important points is that we talk about nociceptive pain, neuropathic, and nociplastic. Remember me talking about those? I bring it up on the podcast.
Yes. Yes.
And we are taught as clinicians and as patients, it's understood that a pain means there's tissue damage, but that's not true. But it feels the exact same as
Yeah.
if there is, but doesn't mean there's any less distress.
Right.
That's why ibuprofen's not working, because it's not
Mhm.
acute inflammation anymore. That only worked right after surgery. So that is part of that. And then look at this as a multifaceted approach in having that. Part of why, before I wrote the book, I had a 2-page handout and then a 20-page handout. And then I'm like, I don't have enough time for all the reasons you said. And a
Right.
huge part of this from a patient perspective is you're telling me that I don't have tissue damage despite feeling pain everywhere.
Right.
And then you talked about functional MRIs that were like a microscope discovering bacteria cause infection. Oh, was revolutionary to say all these years, all of these people who were complaining actually have distress. And
Yes.
then we look at, okay, the central nervous system works differently, right? And that is not less legitimate. And most people, I think, needed that explanation and find it helpful because they know they have something in it. They would have been dead by now if it was cancer that was metastatic everywhere in your body and you've had it for 15, 20 years, right?
Exactly. Exactly. Exactly.
What do you
Yeah.
think about that explanation, those thoughts?
Perfect. Perfect. And you brought up the functional MRI. And so when I read about that, like there are other areas where these functional MRIs have really transformed medicine as well. And I go to Dr. Bernard's book on diabetes and his talk about using the functional MRI to finally lay it home that saturated fat within the cells is the underlying cause of insulin resistance. And people didn't really understand it. We'd known it for 100 years, but until we had that to show us that I think that's when we're hopefully now we're going to be able to move forward. That was like 20 years ago still. But regardless, so when I read that, it was so gratifying to know that yes, there is an organic basis to this. It's not all made up. I'm not just a whiny person, that it's real. And being able to help my patients understand that as well, I think is going to be a real game changer in our clinic. And I also had the blessing to have nurse practitioner students. So I'll have one that's going to be with me in March, and I have another one who will be with me for 2 semesters. So I am excited to be able to continue moving that forward. But to me, that kind of begs the question then that why are we not talking about this more in continuing education or the various training opportunities that we have for NPs and doctors and whatnot? That because we are seeing so much of it, why are there not more opportunities for us to learn this? And
I have thoughts. What are your thoughts?
I
You're
think
more freshly minted than I am, and you work with NP students. What are your thoughts on why that's not happening?
I think a big part of it is that people don't have time to really dig into it, that they're probably spending so much more time getting caught up on how to prescribe the Ozempics and the Wegovy's and dealing with so many other chronic issues that I think we have this wave here that's going to be coming that we're not going to be prepared to deal with. And it could be as well that there may not be a lot of interest there yet because of, again, that lack of understanding that there really is an organic cause to this, so the patients are not making it up. So I think if we can get out and get that word out to the providers that this is something that is indeed real and can be treated, then I think we may be able to get somewhere.
Yeah. And I 100%, if you boil it down, that we reframe, and I talk about this if you've listened to the podcast, it takes a humble physician or clinician to have to admit that they have misclassified 20% of their patients or 20% of their office visits, patients that are coming in because
Yeah.
they come in more often, that they have misclassified them as things like worried well, hysterical, a well woman who pretends or whatever it is, right? Do you think that's when you have probably shadowed, it was probably in the hallway away from the door? Oh, she's back, Sally. Right? Would you say in your training, just spend some time with her about you're in the lifestyle. So just talk about getting good sleep and exercise.
Yeah.
And hopefully that has to change. And unfortunately, it takes 17 years for some commonly understood information to be used routinely. I think some other reasons why, and because there's multiple reasons, is that this is the bastard stepchild of medicine.
Mm-hmm.
Nobody wants to claim them as their own.
Right.
In my opinion, primary care has to be the place these people get treated. And that is the best care. In your clinic system, in your area, rheumatology does not see them. In our area, rheumatology does not see them. So
Yeah.
they're left with pain management, which a person said, oh, should I go back and I got another injection? And then I'm like, no, well, we need to treat your fibro. Putting a needle in your back is not going to cure your shoulder pain.
Right.
It's not going to cure your migraines and
Right.
all of these things. So it takes a humble clinician to have to like say, mea culpa, excuse me, I'm guilty. I have completely brushed off and dismissed this group of patients. And now I have to humbly say, wait a minute, I'm sorry. And most clinicians, probably you including yourself, may have for you, most clinicians not, they'd have the opposite reaction. But you are now looking, oh, I can't wait until Sally comes in and sit because I actually have something I can share with her because I didn't know what to say in the past. So I just said, come back in 6 months. And hopefully she doesn't come in sooner.
Right. Right. Right.
Thanks. Hopefully when we get the thyroid and the normal CBC and SED rate and it's normal and the nurse calls them with normal stuff, they don't go, I'm still hurting and I have pain.
Right. Right. Right.
And,
Right.
and now maybe you can go, hey, I got some things I want you to do. Ahead of time. I want we to talk about this and let's get the process moving. And likely many doctors, if they're humble, will look back at their practice and go, oh my goodness, I misunderstood. I didn't fully understand the extent of what was going on. That's one aspect. And I had been doing these, as I say in the book, I've made these connections for years. I just assumed it was standard of care. Everybody was doing this. And it turned out it isn't the standard of care. This isn't what happens. And then when you bring up the connections with ADHD, and I got listener feedback recently that said, can you talk more about ADHD? And I do talk about it, but so if
Yeah.
you listen to the podcast and it's taught and I try to get a balance, somebody made a review of my book and said, oh, he only talked about ADHD. I'm like, my biggest chapter was about whole food plant-based diet. And we talk about exercise and stress management. All of these are interconnected. I was just at the APSARD conference, American Professional Society of ADHD and Related Disorders. 90% of primary care doctors feel comfortable diagnosing and treating a depression. Less than 30% feel comfortable diagnosing and treating ADHD.
Yeah.
And probably majority of that 30% were pediatricians because I know very few family practice and probably even fewer internists. That's part of their curriculum. And we do not have enough psychiatrists to treat everybody who is in the missed generation who was born before the year 2000, who is now an adult who never got diagnosed. At the conference recently is that if you can reclassify stimulants into the more appropriate category instead of a level 2, a level 3.
Mhm.
You
Uh-huh.
take a handful of Adderall, your blood pressure goes up, your heart races.
Mhm.
You take 30 milligrams of Ativan and you could be dead. 30
Right.
tablets, you could be dead.
Right.
You take 30 tablets of your oxycodone, you could be dead.
Right.
But because of anxiety within the whole Oxycontin problem and other factors, and because of shortages and misunderstanding, and because ADHD is so intertwined with this, and it's an important part because you can only get so far if you don't treat this with your fibromyalgia. It takes really extreme efforts to get through things. That would, I think, help if you could look at using Adderall like you were using duloxetine or
Mhm.
maybe
Uh-huh.
Lyrica, where it's something we watch, but we don't have to watch as care. We have appropriate level of concern. I think that would shift the dynamic to wanting to go there, but often we don't want to get our hands messy. But as you're going to start to see, it's so satisfying to help people who've struggled for the longest time. The area under the curve of depth and duration of suffering is so intense.
Uh-huh. Agreed.
So I would hope that I hope that the book, as you read it, I tried to do the line of intelligent enough that a clinician like yourself can learn, but also at a maybe 10th grade level, not a 6th grade level, but of education. You're a patient who wants an intelligent, not a quick pamphlet glossing over things, but wanted to get into the science and the studies that support this, and you can back it than just a brochure with it. Prior to writing the book, and I don't have a nutrition book on fibromyalgia, but it would be Eat a Plant-Based Diet. And there's tons of plant-based diet books out there. I did not have to write another book on plant-based recipe books, right? But what really drew me also to write the book was update the science along with my clinical experience, and studies were showing the high co-occurrence of ADHD with these chronic pain syndromes. And I thought, let me just look. And right before I really dive into writing this book, there was a book put out by the Mayo Clinic in 2018 or 19. I said, I'm going to look through this book. If they've done a good job, I will not have to write a book. I'll just say, go read this. Just here, go read How Not to Die or How Not to Diet or Dean Ornish or Neil Barnard. They're all speaking essentially the same information, and whatever one you want to start with, to whatever level. But they did not mention the word ADHD once in the whole book.
Oh, wow.
And I'm like, I have to have that. Now, I have no marketing firm. I just all grassroots. I have no, but it's not on this New York Times best-selling list. And also what drove me to do it is other books out there might have some good things, but not always good science on all of the information. And some confusing and counterintuitive things like saying there's a myofascial and using this thing to rub your periphery is going to help, and it's tissue. And you're like, no, it's the central nervous system. You're confusing people. Not that you can't have co-occurring peripheral problems.
Right.
But it offers that. And then often there's this functional medicine component that said, oh, you need to take a special herb, a special supplement, and Laura Valero's special supplement herb option for $39.99 a month, and in combination with a whole food plant-based diet will reverse your fiber. Right. And that's often where people go. And for many times, I'm having to re-educate people who've lost tens of thousands of dollars spending money going down a journey because they at least listened to them for an hour.
Yes.
But then they offer things that aren't that evidence-based. There may be some lifestyle components. You're nodding your head. What are your thoughts on all that?
Oh, I completely agree with that. That with functional medicine, you hit the nail on the head with it. They're taking the time to listen and digging into the patient's symptoms. But I completely agree that the evidence behind what they sell is not there. And so the patients, they want to be heard. They want to be heard, and they want relief. And when you want that, when you need that help, you try to get it wherever you can. And yet that is a challenge. And I do have some patients who have gone to functional medicine. And so I hope to be able to offer them an alternative that is more evidence-based. And that's what I explain to them, is that what we do with lifestyle medicine is evidence-based.
And just to give a summary, people ask, what is lifestyle medicine? Functional medicine is a big PR marketing firm. It shows up on Facebook and all of this. Lifestyle medicine isn't selling anything. If you want to quick summarize what lifestyle medicine is in your own words.
So it's a way to address chronic conditions through the broad application of improving diet and nutrition and sleep and stress management, avoiding risky substances, in a way to create that more holistic health, as opposed to just throwing pills at something. It's addressing, as I tell my patients a lot of times, what I am trying to do is turn off that faucet. Conventional medicine today, you've seen that cartoon where you have the overflowing sink and you have the 3, 4, 5 mops that's trying to mop it up, and you keep having to add more and throw more at it, when really what you need to do is address the upstream cause, turn that faucet off. Lifestyle medicine is attempting to do that healing at the cellular level by getting rid of the junk in the life and doing it in an evidence-based manner.
Hmm. And there's those positive social connections, which are part of that whole bigger picture approach that is weaved so well in with managing chronic illnesses like fibromyalgia and diabetes, obesity, connections with that. A couple questions specific to you, and if you don't want to answer, that's okay. If you've gone through menopause, how much of an impact do you think that's had on fibromyalgia symptoms?
I s- went into menopause. It's been a good 10 years. I was actually in nursing school when that happened. And I never had a hot flash, which was, I cannot explain that. I don't think my mom had them either. So I understand that, you look at what your mom experienced. And my sisters also similarly never really had much in the way of hot flashes. I would say the two areas where it affected my fibromyalgia would have been more in the realm of sleep and the brain fog.
And lot we understand when you look at what brain fog and then you look at what are the symptoms of ADHD, they overlap. Just at the APSARD conference, and I have guests on here who are experts on ADHD, that we're understanding estrogen affects dopamine, and we realize that postmenopausal intensification of symptoms that might be that brain fog or fatigue, the cognitive struggles. You were, it sounds like, probably eating a plant-based diet, so there's studies showing a vegan diet with soybeans has greatly reduced hot flashes. So if you're having those, that's another episode, but that's studies
Right.
supporting. Two things to finish with here. You've now taken the Adderall. It's relatively new, but you are probably hopefully titrated to a dose that's working. Can you give examples of the impact that's had on just broadly and specifically fibromyalgia?
Okay, sure. So broadly, it has improved my ability to. So typically, when I would sit down and try to do paperwork, I would work for a little bit and then I would like maybe look at my phone or maybe look for a snack or that it was just very difficult to sit down and focus and get things done. Just like many people with ADHD, I have about 5,000 unfinished projects that I get excited about something and then I just never finish them. So that was the one thing that I had really noticed off from the very beginning. And like just being able to finish up my charts by the end of the day. I would usually take my days off to finish up my charts. And now I'm getting them done. Even with a busy workload, I'm getting them done. So that has been fantastic. And the other thing I had alluded to it earlier was that I've been dealing with a lot of knee pain from my meniscus repair. We don't know what's going on with my poor knee, but the chronic pain just crowds out everything else. And so since I've started the Adderall, I'm not paying attention to the pain anymore. And it's not bothering me as much. So that alone has been another game changer.
So your pain had markedly improved since being on that?
It has. It has. It might still be there, but I'm not paying attention to it. It's not taking hold of all of my attention. And so that's been really wonderful.
Yeah, a pleasant connection. And your brain fog or cognitive fatigue, what do you think has happened to that?
So I'm doing really well with that as well, being able to, like I said, to be able to concentrate and focus on doing a lot of different tasks. I'm doing the end of the year books. We own a couple of rental homes. So that's very monotonous to go through the spreadsheets and to be able to do that. The other thing I have noticed as well is being with my patients and really being able to focus and listen to them better as well.
Yeah, and makes it more of an enjoyable day, I'm guessing, going through your workday. Is it less burnout feeling or exhaustion feeling about caring for patients? I don't
Yes.
want to put in your
Oh,
mouth.
yeah. Oh, yeah, absolutely. Absolutely. I end the day on time and I feel good.
So let's maybe finish here with speaking to two groups. The first group, let's say all of the clinicians out there who were where you were a year ago, who didn't have this information and maybe knew or heard about it and are just listening, to speak to them.
Sure. That's a good question. So, the first thing I would say is don't be afraid that there are solutions, there are treatments that this can be done in conjunction between you and your patient. So, don't be afraid of these symptoms that don't seem to have an organic cause. You can help your patients.
And what would you say for all of those listeners out there who are patients living with one of these overlapping chronic fibromyalgia and other invisible illnesses?
So be patient. Do recognize that maybe your provider may not have the full swath of training. They may not have the full spectrum of training and bandwidth to be able to diagnose and manage these interconnected conditions. So be patient and be persistent, and help can be out there.
The biggest question I get from listeners across the country is this. One is, Dr. Lenz, do you do virtual visits to people in Virginia or California or other things like that
Right.
within the state of Wisconsin? And they say, do you know anybody else who practices like you do, who understands and treats that? We have at least one clinician that is really ramped up her understanding. Laura Valero, a nurse practitioner. Do you want to say where you're practicing in case people are willing to drive or want to see you, even though you're in a semi-rural area? Can you share where you're practicing?
Sure. I'm in Culpeper, Virginia. We're a small rural community southwest of DC.
Okay. I did my residency in Richmond, Virginia. I think Culpeper is right on the north end of the Shenandoah Park, isn't it? Up that way?
It's it's to the east of the park. So,
Yeah.
yeah.
So if
So,
you're in the Metro DC area and want to have somebody who at least will listen and has understanding, probably be worth the drive. So being on this podcast may end up giving you more patience than you might be
right.
overwhelmed, but you at least got a chance to meet her a little bit. And in case somebody's coming from that Eastern Metro Virginia area, at least for another person. And then hopefully, as you get a chance to interact with nurse practitioners and get their training, hopefully they'll learn from you and carry that forward. I've gotten a chance for 13 years to work with residents and now medical students. And when they work with me, whatever they end up doing, they will know the importance, how we look and treat patients. It's so important that
It's all about
we'll pay it forward.
it's all about patient-centered care and listening to your patients.
Awesome. Again, thank you so much for coming on and sharing your wisdom and experience and your own personal journey with fibromyalgia.
Thank you. It has been a true pleasure.